Good morning, everyone. I'm Dr. Martin. This is the Institute of Regenerative Education, and we're going to do a bit of an aesthetics recap here. Apologize, I'm not wearing a coat. I'm usually suited up. I got some lovely bug from my daughter who flew in and flew out, and she came in and we bought her a bunch of clothes for her new job, and she flew out and she left me with a hug and a terrible viral thing. So my body temperature's like 110 right now. So I'm sweating through everything. Most of you are using regenerative therapies, and it's for musculoskeletal applications, but there is just a huge market segment out there for aesthetics, right? We know that per the FDA, which is your friend, right, the only two kind of uber safe harbors are cosmetic topical use and experimental use. We've done plenty of videos on how to do research in your practice, how to participate in some of our very large IRBs so that you can actually document experimental use. But hollowed and safe ground has always been aesthetics, right? There are some laws that are changing, specifically in California, about who can microneedle, who can't microneedle. But we're going to review videos that we've done in the past, and we're going to try to be quick about this because I know everyone's busy. And we're just going to do a bit of a refresher, all right? Now, if I'm looking at the face in general, all right, the majority of aesthetics that are applied for the face, right, are applied for a couple reasons. They are either applied for scalp or for facial reasons, all right? Those are the two most profitable paradigms in aesthetics. Everyone who's doing aesthetics understands that you are either breaking even or you are losing money doing Botox. Everyone gets that. But Botox is a lovely funnel. But that funnel is shifting. More and more providers are starting to use aesthetics in general for the face. And where are they using aesthetics? Scalp restoration and face restoration. Now, why? What is kind of fueling this issue? Well, I'll tell you. It is being fueled by GLP-1s, right? GLP-1s are the gift that keeps on giving. 30 to 40% of the US population is on some type of GLP-1, whether it's compounded, whether it's prescription, whether it's over the counter. 40% of the US population. Now, what do you get with GLP-1s? Well, what you get with GLP-1s, and I can take this off. I forgot I had the other microphone. What you get with GLP-1s is interesting. What you get with a GLP-1 is you're going to get what I called a long time ago the Ozempic ooze, meaning your hair is going to ooze off your face. The fat in your face is going to ooze. And this is why you see these uber gaunt celebrities who go from kind of hollowed out husks that vampires just sucked all the blood out of. And there's a whole other thing there with Hollywood. To kind of this big bloated, overfilled look, right? And it's because they got thin on GLP-1s. But GLP-1s, while reducing fat, also cause sarcopenia. And you get this gauntness to the face, where you get hollowing under the eyes, you get hollowing in the temples, you lose your hair. Nasolabial folds become more prominent. And so when we are talking about the application of biologics, most people are living over here. And over here are the synthetics. What do I mean by synthetics? That's platelet-derived growth factor. That's HA. highly cross-linked HA. That's Radius. That's Sculptra. All right, that's Juvederm. And on and on and on, right? Why do I consider these synthetic? Well, number one, they are, right? Number two, every one of these fillers is predicated on a macrophage-induced paradigm. Macrophages engulf the foreign body, and all of these are a foreign body. And they generate what? They generate a type 1 collagen-driven response. Macrophage engulfs the foreign body. Body encapsulates that foreign body with fibrin, scar tissue. The reason we get filler face with all of these, because they are all synthetic, is very simple. If I shot 50 million little barbs in your face and they got implanted into the dermis, your body is not going to purge all of those. Your body is going, based on macrophage-driven paradigms, M1, macrophage-driven activity, engulf them because they're a foreign body, create inflammation, swelling, scar the area with type 1 collagen, and set up an osmotic gradient where you're going to see a bloom. We see this with highly cross-linked HA. That was the first. We see this with PLLA. We see this with calcium hydroxyapatite. We see this with the yeast biomass protein that is platelet-derived growth factor. If you don't know what platelet-derived growth factor is, it's not platelets. It's yeast biomass protein. It's completely synthetic. Juvederm, different type of synthetic HA. All of those products, the foundational literature for every single one of them was built to feign that they enhance type 1 and type 3 collagen. This is a lie. This does not happen. The reason it does not happen is because in the foundational literature for all of these, what did they do with Radius, Sculptra, platelet-derived growth factor? They combined the products with fetal bovine serum. Does this sound familiar? Who else did that? Oh yeah, folks that did the in vitro and vivo studies for bone marrow aspirate concentrate. Folks that did in vitro, in vivo for PRP and stromal fraction, right? All of them combined their products with fetal bovine serum. What does fetal bovine serum do? It's a super soup. It's a super serum. It dramatically improves the viability of that biologic in vitro. It has collagen-based growth factors, lots of them, including type 1 and type 3. All right? So is it any wonder that when they incubated this with this super soup, right, and then cultured it on cultured media for anywhere between, a month and 2 months, right, and then buffered it more with other collagen-based growth factor products, and you can see this in all of the foundational literature, and then injected that, their Radius, their collagen-rich, soup, their, aggregated collagen-based growth factors that they basically spiked it with on top of the fetal bovine serum, and then cultured it in a petri dish, and then injected it into the face, and then did a biopsy 30 days later, and in the region of the biopsy discovered type 1 and type 3 collagen. That doesn't mean the product created type 3 collagen. It means that they found type 3 collagen in the region. The marketing department just made the leap that if you inject it, you're going to get type 1 and type 3. Now, we know it's not true. And the reason we know it's not true is we have plastic surgeons all over the country who are doing deep plane facelifts, and they have to dissolve out the type 1 collagen with hyaluronidase. What does hyaluronidase dissolve? It dissolves type 1 collagen primarily. That's what it's meant for. That's what it does, right? If they were injecting hyaluronidase everywhere to break up all this scar tissue and it dissolved everything else, that would be terrible, but it doesn't. It breaks up type 1 collagen primarily because that's what's there. Seeing little chunks of radius all over the face, agglomerated in little chunks that you can see with the naked eye on some of these deep plane facelifts. Now, there are people that still want this overfilled look. They still want to look like, you know, some of the wealthiest peoples in the world, their wife, right? With these big, huge lips and this big puffy face. And that's still, you know, hot in Hollywood. Not everyone wants that anymore, right? I mean, we know that filler face can persist now for 10 years. So what's the alternative? Well, the alternative is all natural. Now, all natural is not plated, right? Platelet-derived exosomes put in some solution, made probably 3 years ago, sat on the shelf in a warehouse and then shipped to you for $200 or $300 a unit. And oh, there's definitely going to be some viable exosomes in there. No, there's not. Red blood cells die in the human body in 3 days. So after you've created the exosomes from the platelets, and there's not that many anyway, right? What are you going to do with them, right? They're going to stay viable in what? Something you just put on the shelf at room temperature? No shot that's going to have any viable exosomes. Maybe some proteins and some peptides, but it's a wonderfully sold product that's complete nonsense. There's no sustained viability in that product. So what is all natural? What is all natural is going to be umbilical cord derived biologics. I'm sorry, it's true, right? Yes, there's fat-derived biologics out there. There's a new fat-derived product for injection that they're trying to get FDA approved. I wouldn't inject that. Anyone who's ever done liposuction or fat transfer, try to get the red blood cells out of that. Just try to wash the red blood cells out. But you're doing autologous transfer. We're talking about using lots and lots of fat-derived biologic and injecting it, not microneedling, injecting it in the body, right? I mean, how do we prevent a graft-versus-host? How do we do that? Knowing for sure the fat is going to have Rh factors and antigens on it. Okay, well, we're going to clean all the Rh antigens off it. We're going to sterilize the whole thing. It's going to be lyophilized, dead fat. Okay. So are there any viable exosomes in that if it's just completely scorched earth, dead fat? Now there's just going to be dead fat cells. What exactly am I going to get when I reconstitute dead fat cells with HA? I'm just going to get a hyperosmolar soup that when I inject is going to draw water into it and give you a transient bloom. It's a fugazi. It's a bullshit product. Just mix collagen with HA and inject it. It's the same thing, right? It's just going to create a hyperosmolar paradigm that because there's a concentration gradient will draw water to it and it will cause a bloom. It doesn't mean it's going to actually stimulate type 1 or type 3 collagen. Remember, collagenic differentiation depends on what? Number one, resolving inflammation. You can't build a house in a hurricane. You got to get rid of the inflammation. How do all of these work? Oh, they work by way of a pro-inflammatory response. That's how all of this works. Pro-inflammatory response. Well, can we build a house in a hurricane? No, we cannot. So are you really building any healthy type 1 and type 3 collagen knowing that you're causing inflammation with all of these? No, you're not. How do natural source biologics work? Oh, they downregulate inflammation. They work by way of an M2 macrophage pathway to downregulate IL-1 beta, to downregulate, to upregulate IL-10, to upregulate ARG1. Not anti-inflammatory. Anti-inflammatory is a drug. They downregulate inflammation. They work by way of an M2 macrophage pathway. This is all M1 macrophage. This is Cox and LOX pathway. This is outside of Cox and LOX pathways. Why are umbilical cord biologics, exosomes, Wharton's jelly, why are these beneficial for aesthetics? Well, what is Wharton's jelly inherently? Inherently in the cord, type 1 collagen, type 3 collagen, hyaluronic acid, and extracellular matrix. Fabulous, fabulous product, considering the fact that dermis is what? Type 1 collagen, type 3 collagen, and hyaluronic acid. I mean, this is not hard. This isn't rocket science. Why do we use exosomes? Well, what are exosomes? Well, they also have collagen-based growth factors, right? Type 1 and type 3, right? You're not going to see HA, you're not going to see extracellular matrix, but what do exosomes do? Potently down-regulate inflammation. Awesome. They also have the most concentrated vascular endothelial growth factor and placental growth factor. What happens in the lips? As we age, our lips lose vertical height and forward protrusion. The pinkness in the lips is 100% dependent on the concentration and density and diameter of blood vessels in the vermis of the lip. As we age, those blood vessels become smaller, they become fewer, and as a result, our lips get paler. So if I were to put anything with vascular endothelial growth factor and platelet-derived growth factor, which is also in Wharton's jelly, right? Placental growth factor. Am I going to pink the lips up naturally? You betcha. But what do exosomes also have? Interestingly, they have growth differentiating factor 11, which does what? It stimulates tropoelastin. And what is tropoelastin? Oh, tropoelastin is the precursor for elastogenesis. I always get the question, well, I mean, I get this wonderful bloom with HA. Am I going to get a bloom with any of these? No. You're going to fill to the level of the defect because it's a natural source biologic. You're not going to overfill the face. And this has become very on trend in places like Manhattan and now, you know, Naples and Coral Gables and areas outside Miami proper, where they're still very overfilled in Miami, but it's starting to move into Miami. Now, why are other providers using things like Wharton's jelly, and in particular a flowable Wharton's jelly, something called NanoFlow, in places like the lips? Well, NanoFlow is an MSC-derived secretome. It's 40 million to 80 million MSC-derived growth factors in a flowable solution that you can push through a 31-gauge needle, which means you will not get a vaso-occlusive crisis. Can you get a vaso-occlusive crisis putting Juvederm or highly cross-linked HA in the lips? You betcha. This, zero risk of a vaso-occlusive crisis. None. Now, practically speaking, this is a lot of information. This is all the science, right? How do I break this up into an elementary understanding? Because I have patients that are coming in looking for all this stuff. But I'm trying to tell patients, look, I think this is going to be safer for you. That is the point. I just want to do the Jim Carrey and rewind here, right? Like he did in Ace Ventura. All of these are predicated on massaged literature, where they did something you can't do in your office. You are not going to take Radius, culture it with fetal bovine serum, spike it with collagen-based growth factors, incubate it on a slide, scrape it off, and then inject it in someone's face. You ain't going to do that. So are you going to be able to replicate what they say it does in your office? You are not. Will you get an unnatural bloom? Yes. Society for 10, 15 years thought that that looked good. Well, Asians thought it was a great idea to bind the feet of girls and take women with size 7 feet and bind them and destroy the bones in their feet so they could fit into these little teeny tiny petite slippers, right? Look at some of the feet on some of these women from Asia that wore the lotus slipper and tell me if that was good for them long term. Trust me, it's not, right? Just so they could wear the little lotus slippers and Asian men, could fetish out about that. This is the lotus slipper for the face. All of this is lotus slipper for the face. And when you finally take the lotus slipper off and you see the destroyed, broken foot, you're not seeing it, but plastic surgeons are. And they're documenting it every single day. Now, have we seen any litigation from patients coming back and saying, hey, I had to spend an extra $5,000 for my deep plane facelift because my surgeon spent almost an hour dissolving out all of my filler? No, you're not seeing that. All right, will we see it? Absolutely. Someone is going to come out of a deep plane facelift and they're going to be like, wow, you told me it was going to be 11,000. What's the 16 grand? I spent an hour dissolving all your filler. I spent $50,000 for fillers over the past 5-7 years. Yeah, that's great, but I had to dissolve it all out to give you what you want in a facelift because I couldn't leave all that crap in there and give you the aesthetic appearance that you paid for. As a matter of fact, I wouldn't. It's unethical to leave that all in there. Oh, well, I'm going to get that $5,000 back from my esthetician. It's coming. And you can take it to the bank from me right now. If there isn't a documented case out there, it's coming, right? Because plastic surgeons are seeing this over and over and over again. This is not to dissuade you from this, right? This might make you money. It might give you a transient aesthetic appearance that your patient might want. They may come in and say, hey, look, I want this. All right? Lots of patients coming in saying they want, peptides and all sorts of things, right? Lots of women coming in saying they want high-dose testosterone because they want to invigorate their, sexual wellness, whatever, right? What are the long-standing benefits of that? Well, in certain patients, it might be okay. Is it okay for everyone? Maybe not. If I put something like this, which is going to have a pro-inflammatory response, in a prolonged M1 macrophage-driven paradigm for years, if I put this in somebody who's immunocompromised, 2 COVID vaccines, 4 boosters, long COVID, maybe chronic Lyme, what happens? We don't have any idea. The natural history of this is if I put this foreign body in, because it's going to cause inflammation, I am depending on an intact immune system in the dermis to remodel inflammation, scar that area down. What if their immune system isn't robust? And you put filler in somebody's face and they're a sick patient. They want to look good because they just want to look pretty because they feel terrible inside. And then they get this massive swelling everywhere, this borderline anasarca. And we've seen this in patients with HA and radius and even Sculptra, where they get filler and their whole face blows up. And everyone's like, oh, they must have had an allergic reaction. They didn't have an allergic reaction. That was an intended reaction. It wasn't an allergic reaction. They weren't allergic to the product. Their immune system's trashed. And you put something in their face everywhere that's going to induce inflammation, and their body simply can't remodel that inflammation. To everyone who's practicing medicine in February 2026, your patients are more sick today than they ever have been. All of this post-COVID era, we're seeing more chronic disease, autoimmune disease than we ever have before. Patients are not simple patients. Your standard patient who looks cute, who comes in soccer mom in her whatever Philip Plain outfit and her cute little jogging shorts and her whatever, Golden Goose sneakers and, her rack of Cartier bands and, her Patek watch, right? Who knows? She could have lupus. She could have Hashimoto's thyroiditis. She could have any and all sorts of things. And you're going to make her look good, but you're not looking past the skin. And because you're not looking past the skin, you're putting a foreign body in her face that's going to mount a foreign body response. And are you ready for that outcome if she ends up getting an inflammatory response and her body can't remodel it quickly or effectively? Most of you are not. Most of you haven't even considered it because you're just doing what the rep told you. And as I've told you in countless videos over and over again, in front of a jury of your peers, what the rep told me is not going to save you from a medical board investigation. What the liaison or scientific advisor from the company told me is not going to save you from a jury of your peers. I don't care if it's a doctor who's getting paid as a consultant for Juvederm or Radius or whatever else. All aesthetic medicine still falls secondary to what? It falls second to the common sense, evidence-based practice of medicine. I don't care whether you're doing scalp restoration or under eyes or nasolabial folds or lips. I don't care if you're microneedling. I don't care if you're injecting down deep on the cheekbones or on the temples. I don't care what you're doing. It all falls second to the common sense practice and evidence-based practice of medicine. So if all you're doing is saying, oh my God, you're beautiful, let's just touch up here, touch up there, and you're not getting any history from your patients, buyer beware. Not even asking patients, whether they have a sensitivity to lidocaine or epinephrine, knowing that dilute Radius, dilute Sculptra has lidocaine in it, right? And you're dumping lots of that in the patient. May have some issues. I bring the point not to even talk about the application, but to talk about the genre, the aesthetics genre that you're practicing in, and show you visually what has been done, and at least in larger and larger areas of the country, what is being done. I don't know how much longer all this will be done because I don't know how many voices other than plastic surgeons are out there telling you what this is doing to people's faces other than me. And that's okay, right? Because eventually others will. But this is more than likely what should be done. This is not a foreign body response. This is not mounting inflammation. This is not putting a foreign body in the face. A living, breathing, moving entity. The skin is the largest organ in the body. And you're throwing artificial, synthetic stuff in it at times monthly. And you're expecting the body to handle it without issue. And I'm here to tell you, eventually, you're going to put this in the wrong patient who has an impaired immune system and you are going to meet the inevitable result of taking a foreign body with an inherent pro-inflammatory response that works by way of M1 macrophage-induced phagocytosis with type 1 collagen formation around it, that is then going to create a profound inflammatory response, and one of your patients is going to go to the hospital. And they're going to make a call to some 3-letter agency or to a medical board, and you're going to have to say how and why you felt comfortable doing that. I understand that I am kind of the lone goose out here taking all of the headwind in the face, and believe me, I take a lot because nobody's saying this. But just because no one is saying it doesn't mean somebody should. And I'm the one who is. I'm Dr. Martin. Have a very blessed day.